Okay, welcome everyone. Merci beaucoup, Dr. Olivier. It's a pleasure for me to talk here, and I'm quite impressed by the big turnout for this great cause. So I'm here to explain to you cardiac CT. That's why we're all here, so let's learn more about it. Now, we've learned how important coronary artery disease is by Dr. Chamoun and the evolution of CT scanners by Dr. Olivier. And they've come a long way in the past decade and a bit. At first, Dr. Callender developed the one-slice single detector CT. So there was one detector that would spin like a slice, a helix, around the patient, and the table would move slowly. And that was great for acquiring most applications if you wanted to scan the head or the chest. But a heart, which measures about 8 centimeters top to bottom, that was moving, you couldn't really scan it this way. And how technology evolved a few years after that is how about we add a bunch of detectors, several detectors, and that's how cardiac CT started off. So you had several detectors covering several centimeters, and that would scan. Each slice, scanning around the patient, would cover a bit more area, and that's how cardiac CT started about a decade or so ago. And this is what it looked like. This is just a diagram. So at the top you have an ECG tracing. You need to put ECG leads on the patient and map out the heartbeat to the CT scanner, and you relay this information. There's a purple bar that's running at the top, and that's basically the CT scanner that's on and is taking an entire picture of the heart through multiple beats. And that was okay, and it worked well, but it had some limitations. Number one, it was slow, because you had to take multiple beats, not that big of a slice, and it was scanning around the patient. It was also sensitive to if there was irregular heartbeats. You can imagine if you're going to stitch all this together, but the heart beats like this and then beats like that, and it changes. When it's stitched together, it's going to be irregular. Also, you were acquiring a top of the heart at a different time point than the bottom of the heart in terms of a heartbeat. So this anatomy was different across the different time points. And you injected dye, and when it would run through, that dye was obviously not staying in one spot. It was following blood, and so that dye was not uniform across the entire heart. Probably one of the bigger ones too was a bigger radiation dose. Because the scanner was on, that purple bar the entire time, you were getting doses, and we use millisieverts, and I'll give you a reference point. It was about 8 to 17 millisieverts. If you were alive for a year at sea level, you get about 3 millisieverts. If you were getting a chest x-ray, you get 0.1 millisieverts. That's the equivalent to being just alive for about 10 days. So the radiation dose in these early CTs was higher. So they said, well, maybe we don't need to take a picture of the heart the entire time. Let's do a step and shoot. So you tell the CT scanner that you just want to take a picture around right here, and you do it across multiple beats. So that's what it looks like. Take a picture there, table moves down, take another picture of the heart, et cetera, and then you stitch it all together. And that was the next generation of CT, probably how it's most commonly done on older generation CTs, and done in a lot of hospitals actually currently. And this was also good, but you needed a heartbeat to move the table. You also had longer scan times because you had multiple heartbeats, and therefore more contrast dose, and still a little higher radiation dose, but not as high as the other method. And again, you had some non-uniformity. You also had this banding or stitching artifact that was more prominent compared to the other way because you were actually stitching different scans together. So CT or MDCT, multi-detector CT, evolved. At first it was 4 detectors that covered about 2 millimeters, evolved to 16 detectors, 64 detectors, which is what Montfort currently have and a lot of hospitals do. This is what was most commonly used to do this step and shoot method or stitching method, and that covered about 3.2 centimeters. There was an 80 detector that came out a few years later, but not significantly different from the 64 detector. Well, the technology that Montfort is going to acquire, or this Toshiba Aquilion 1 CT, has 320 detectors. So that's 16 centimeters. So that's a 4-fold change from technology to technology. If you make a parallel to computers, imagine getting something 4 times more performant. That's where we're going for here. And I mentioned that the top of the heart to the bottom of the heart is 8 centimeters. Well, this covers it in one spin, with some at the top and some at the bottom, because not everyone's heart is the same. It's a very concise machine. This is the donut of where the bore or the gantry where the images are taken. There's no external moving parts. You just hear a little bit of a buzzing noise, and that's it, and it's very quick. And this table can be moved in many different directions, which is very useful for a variety of patient sizes and applications. And here's a nice diagram that basically shows you how fast a 320 slice cardiac CT works. I'll play this. So this is, again, the ECG tracing, and you're going to tell the CT scanner that you want to take a picture here. This is the patient, obviously the heart. Patient's arm would be at the top. And you run the machine, ECG goes, machine spins, boop, picture taken, machine stops, works for a few seconds, and then there you go, got your picture. So that's a fraction of a second. That's how quick it was. So that moment, the moment of radiation that the patient is getting is only that thin little bar. That's how quick it is. And just how quick can it be? Well, we can get it down to 0.275 seconds. So almost a quarter of a second, pretty much hovering around a third of a second. That's as like you snap your finger and the picture is taken. Why is that important? Well, the heart's a moving organ, obviously. It's a small one, and these coronary arteries that Dr. Chamoun talked about are only a few millimeters thick. So if something's moving, and they're tiny, and they're not always the same place, you really want to have the highest technology to be able to take a picture of these and be able to assess plaque, which is even smaller than the artery. So that's why you need this highest end technology to be able to diagnose it. And so basically, in one heartbeat, you can get the entire heart, one phase of contrast, basically one pass of this contrast through the blood system. You don't only get the heart, but you get around the entire lungs around the area in one pass. And this is all in one spin of the scan. So one scan, no need to repeat it multiple times. And this is basically pictures that we get on a day-to-day basis for looking at the plaques in the vessels. Here you have the heart, and these are the coronary arteries all laid out. And so the radiologist or the cardiologist that's looking at the pictures basically has this on their console, and you run every major artery down, and you look for any tiny plaques, and you can get in multiple different views. And this one, remember I talked before, 8 to 17 millisieverts for the initial dose of radiation for the first CTs. We can get this down to below 1 millisievert. So this one can be down to 0.8. So this is extremely low radiation. And the population base that typically gets cardiac CTs are a bit older, so the radiation is not really an issue in that case. But the significant change, almost a 10-fold change in radiation, is very significant. And you can make movies. If you want to show a 3D view, sometimes the cardiac surgeons need this information for mapping it out so they get an exact picture of what they're going to see when they get in there. It's great to have fancy hardware and the state-of-the-art, but you also need software that's state-of-the-art to back it up, and this machine is also paired with such software. One of these, for example, is we know that you can imagine plaque that has a lot of calcium is very bright, and stents, like Dr. Chamoun talked about, are very bright. Well, bright sort of shadows out things in small vessels, and so it's known as artifact. And it's known that this is one of the pitfalls of coronary artery imaging. Well, newer software can actually subtract. What it does, it takes the bright from a stent or a calcified plaque, takes the bright from the contrast that went through, and basically does an algorithm and subtracts it and can give you a picture of what the lumen looks like, or inside the vessel, and that's what it looks like here. This is relatively recent technology that's now able to assess these kind of difficult cases. And it doesn't just do coronary arteries, you can also assess the heart muscle. Mind you, this is not the most common indication for it, but for example here, in this yellow box, you have a plaque that's blocking up this artery. Stress means that we gave medication and basically stressed the heart, and this donut here is a cut of the left ventricle, and the red is the heart muscle. So you've stressed the heart medically, and you can see, and this is at rest without the stressing, and this blue area is an area that has decreased perfusion or decreased blood flow. So you're able to say, oh, that heart part is not working well at stress. And again, this CT is not just for cardiac imaging. This CT is going to be used for a whole host of basically everything done at Montfort for CT. It does, if a patient comes through the emerge and needs a CT of the head or a chest or of the belly, same thing in ICU or on the ward. And then the whole host of patients coming from just outpatient, day-to-day stuff ordered by their family doctor or other referring services. This CT can be done. It just happens to be high-end technology optimized for cardiac CT. To give you an example, this is a patient who was found to have an abnormal tangle of blood vessels in the brain. It's a similar picture that what Dr. Olivier showed. Well, because of how fast it is, we can basically capture a movie of these blood vessels coming into the brain and help with the clinicians mapping out how they're going to treat it. And this is what the video would look like. And once it stops, you can see here that this is this tangle, an aneurysm or a vascular malformation. And you can play this slowly, and you can see exactly which vessel is coming in to touch that vascular malformation. So to go back, well, why is this important, fancy technology, but why is this important? Well, it basically ties into what Dr. Chamoun said. We know that coronary artery disease is a top killer, like he said. It's very important, multiple causes, and can cause serious problems such as chest pain, heart attack, death, irregular heartbeats, cardiac failure, cardiac decompensation, like he mentioned. And coronary artery CT can find these, and can find these very well, almost as good as catheter angiogram. Now, cardiac CT will never replace all of those. It won't replace ultrasound. It won't replace nuclear medicine. But it's still very useful for detecting these plaques non-invasively. So here you have a picture of the heart and the plaques, and then we can see these white calcified plaques are all over the place, and we would basically comment on most of these or all of these and tell you exactly where they are and basically give a roadmap to the referring physician so they know the burden of plaque in this patient. And you can quantify it. You can say this is 30%, 50%, 60%, and so on. And like was mentioned, it has very good correlation with what plaques look like on catheter angiogram, which is the gold standard. You always have to have the gold standard to compare to, and this is what it looks like. And this is on your CT, the 3D volume, and this is the typical image that we would use on a day-to-day basis to diagnose these plaques. So you can see that they mirror each other very well. Now, technology evolves, and cardiac CT is not necessarily in its infancy, but maybe its teenagehood in terms of where it's at with proven indications. And it's become quite so proven that multiple major institutions, the American Heart Association and this alphabet soup of people, have come out with guidelines about how we're going to use cardiac CT. And cardiac CT, basically now its indications, I won't read the slide for you, but I'll summarize it, is it's a very good test to rule out disease. It's not made for the test where the patient is having a heart attack, or you think that there's a very high risk or high risk. That patient should go on to an angiogram if indicated. Because if you do a CT and you diagnose plaque, you can't do anything about it on the spot, so you're wasting time. So the cardiac CT is very useful for the patient where there's lower intermediate risk, and you just want to make sure that they have no plaque. So it has very high negative predictive value. The patient comes into the emerge and they are having chest pain, but the workup is negative for heart disease, biochemically, ECG, clinically, but you still suspect it. If you did a CT and they have no plaque or very little, they almost get out of jail free card from a cardiac standpoint for about 5 years. So that's how powerful it is. Same thing for people on the ward. If they're sitting on the ward, they're waiting a transfer to the Heart Institute, for example, for a catheter angiogram, and they're of lower intermediate risk, and you do a cardiac CT. If they have no plaque, there's no cardiac cause for this problem here. There's also other reasons to investigate it. If you have anomalies of the coronary arteries, the heart itself, and because this is an evolving technology and all of these guidelines were based on a 64 slice quality CT, don't be surprised in the next 5-10 years plus that cardiac CT will take a bigger and bigger role in terms of its importance. So we're at the forefront of this evolving technology. So to summarize the advantages, it's very quick. Less than a second to me is pretty quick. It's non-invasive. There's no putting a catheter in anywhere. You have to give dye, so you put a little IV in, like same way as drawing blood off. It's highly accurate. It shows the plaque that it should show, and like I mentioned, it's very useful for negative prediction. You can have very high anatomical detail, and you can see the heart as well as outside the heart. And that is all. Thank you.